So she got a little bit already. So we've got a great topic tonight. We always get asked about the impact of your body mass index on your success rate when you're doing fertility treatments, in particular for IVF. And a lot of people are told, unfortunately, in very insensitive terms that they should just go lose some weight. And that's really difficult for a lot of people to hear. And we don't want to have people have to go through that. So we've figured, why not kind of share the data on this? And a great new study is coming out where they reviewed a huge number of other studies, all compiled together. They had almost 1 million patients or 1 million cycles that people had done. And they examined the relationship between their body mass index only in studies that had controlled for other confounding factors, and then came up with kind of a model or a predictive model for clinical pregnancy rate, live birth rate, and miscarriage. So I thought it was important to share that data with you so we can kind of define where the limits are, what's true, what's not true. Does body mass index actually have an impact? Because it's not fair to tell patients, hey, just go lose some weight. And if you are going to tell them that they need to reduce their body mass index, then you need to give them justification for it. So the question was, is there justification for it? And that's what we're going to talk about tonight. So hopefully in the meantime, while everybody's jumping on board, you're all staying safe. I hope you're all wearing your masks. For those of you that have had the opportunity to get the vaccine, definitely do so. Brand new data came out day before yesterday, I believe, which showed that the antibodies to COVID do pass from mom to the infant through the placenta, which means that taking the COVID vaccine will protect your baby because the baby will be born with the antibodies to the COVID vaccine. So that can be very helpful for the baby. We're still not seeing any kind of significant risks from taking the vaccine in pregnant patients. And there is no risk other than sort of a more severe nature of the illness in women that get actual COVID virus. So if you have that chance to get vaccinated, please do so. It is much safer for you and for your child. But if you are getting vaccinated and you're trying to conceive, they do recommend that you wait 6 to 8 weeks between the time that you took your first shot and the time that you start trying to conceive. So if you're getting vaccinated, we will put about a 2-month block in there before you do your IVF. Check out our YouTube video. Link is right there on the COVID vaccine. And we're actually going to update it hopefully this week with another new video that Tarek and I will work on the weekend. So let's get started. So the name of this article is a non-linear dose-response relation of female body mass index and in vitro fertilization outcomes. So big disclaimer right from the outset, and that is that this study mainly looked at women. And there is no question that we know that men also have a significant role to play and that their body mass index does have a significant role as well. And somebody actually astutely paid attention to the questions and they asked about that already. And I think I put a response up. So if you're male and you are obese, you definitely have a decline in your sperm performance. You'll have extra estrogen levels, lower testosterone levels. We see differences in morphology and motility in sperm count. Frequently there's excessive heat that can be quite damaging. There's DNA fragmentation parameters that can be altered. So the miscarriage rates can be higher, the fertilization rates can be lower, implantation can be lower. So this talk by no means is designed to isolate the women or pick on the women whatsoever. In fact, guys have an equally important role. Unfortunately, we don't have as much data on men, but there is no question that guys need to reduce their weight, eat healthy, monitor their diet, watch their social habits if they are part of this process. So make sure that your guys or partners are doing all of the right things that they need to in order to maximize their sperm. And a big part of that is reducing weight if that's part of their journey. So for the women, this study actually took other studies that had previously been done, and they amalgamated them into sort of a meta-analysis to see what the results would be. And they broke it down into studies that exclusively were cohort studies, so they were following large populations of women going through IVF, and this was exclusive to IVF. And then they analyzed them based on 5-unit increments. So sort of 20 to 25, 26 to 30, and then 30 to 35, or 31 to 35, and then higher. And they also analyzed it exclusively based on certain criteria. So the study went for articles that were from 1988 to March 2020. So that was really important. So it's an up-to-date study. They're including as much data as they possibly can. And they wanted to see cohort-based studies that evaluated the association between BMI and IVF, original articles that reported independently derived data. They reported the number of cases and controls for at least 3 or more BMI categories. And then they reported adjusted relative risks, which means that they controlled for the confounding factors and they put them in there. And they had confidence intervals in there as well. And so they looked at all of those, and if they saw studies that didn't have those criteria, then they excluded them. So this is pretty robust data because the numbers that they're getting are quite strong because the data selection process is quite stringent. So they actually started with a huge number of studies, which is usual with any meta-analysis. There were 713, and by the time they ended, they're down from 713 to just 18 studies. But at the end of the day, these were 18 very well done studies, and they had selected out all of the other ones that weren't critical enough or meeting the criteria. So we're going to pop up table 2, and this will actually be a relatively short talk tonight because there's all the data kind of crammed into table 2. So I want to review table 2 with you. So the first thing we're going to look at is the clinical pregnancy rate. So when you look at the clinical pregnancy rate, for every 5-unit increment in BMI increase above 20 to 25, they saw a 5% decrease in clinical pregnancy rate. So if you're in that sort of overweight category, 26 to 30 or 25 to 30, you're looking at a 5% decrease. If you went from 31 to 35, that would be a 10% decrease. And then if you went from 35 and above, you would see a 15% decrease in success. When they looked at this broken down into fresh embryos versus frozen embryos, because some people say, well, it doesn't matter as much with frozen versus fresh. They thought maybe the fresh is impacted, but the frozen is not. And there is actually some data to suggest that. These guys actually showed in a very highly statistically significant fashion that that's actually not the case. It's 4% lower with fresh, and it's 5% lower with frozen. So it's still very significant. And then they broke it down based on the source of the eggs, whether it was the patient's own eggs or they were using a donor cycle. And this is kind of novel data. I'd never seen this before in terms of a large-scale study like this, looking at donor eggs, because some patients are just worried about the look of the donor or if they like the donor, if it's a known donation. But you do need to take their body mass index into account, because here, again, in a very, very highly statistically significant number, they demonstrated a 4% decrease if it's your own eggs and a 6% decrease if it was the eggs of a donor. So that means by the time the donor is in a sort of more obese category, you're looking at up to a 12 to 18% decrease in the success rate. So that's very substantial. Our donor program has an extraordinarily high success rate, and we don't want to see that go down. So we are strict about the body mass index, and that's important for our donor agencies to know as much as it is for our patients to know, because when you're selecting the donor, we need to make sure they're picking the right person for you. So then we can switch over to live birth. That's always the holy grail of all things IVF. You should be seeing that up there now. And in the live birth category, it's an even higher impact. So it's a 7% decrease overall for every 5-unit increment in your body mass index. When you looked at fresh embryo transfers, it was 5%. When you looked at frozen embryo transfers, it's a 9% alteration in your success rate. So that means if your body mass index is over 35, you're looking at up to a 27% or greater decline in your success rate compared to women who are in the normal body mass index range. So this is very, very important to pass on to people, especially considering those who are doing a frozen embryo transfer. In large part, this would apply to our PCOS women who struggle with their weight. They're going to need to pay particular attention to this because they may make tons of embryos, but we often have to freeze them in order to avoid a hyperstimulation syndrome scenario. and to get the embryos placed into a frozen prepared endometrium where the risk of hypertensive disorders, growth restriction is smaller. In those situations, though, if they are dealing with a battle with their weight or their body mass index, you are looking at this very significant decline in success. Again, when they broke it down into donor versus the autologous or your own eggs, autologous had a 5% decrease. The donors had that 9% decline. So very, very significant numbers and really important to see. When they looked at miscarriage, miscarriage again is very, very interesting to look at. So this is again fairly novel data. We've always known that body mass index has an association, but they were really able to break this down very nicely into the different categories again, which is super important for you guys to know about. So overall, a 9% increase in miscarriage rate for every 5-unit increment. So again, compared to your normal body mass index, when you're going from the normal range up into overweight, you're looking at a 9% increase in your risk of miscarriage. When you go from overweight to obese, you're looking at an 18%. And then when you go from obese to morbidly obese, or the class 3 obesity, you're now looking at patients who are getting a 27%. So that's almost between a quarter to a third decrease in your success rate, or sorry, your miscarriage rate when you are struggling with your weight, and it's quite elevated. They again broke it down into the embryo transfer strategy. So if it's fresh, it's 7%. If it is a frozen embryo transfer, and your body mass index is elevated, it is a 17% increase in your miscarriage rate based on your 5-unit increment of the body mass index. So this is very, very drastic, because this means that for women who are struggling with their weight, going into a frozen embryo transfer, you're looking at a 50% decrease in your success rate once you are into the morbidly obese category if you're doing a frozen embryo transfer. So these are patients where we really need to work with you to try and adjust that before we get you to the embryo transfer, and ideally even before the egg retrieval, to maximize your success rate and give you a much better chance than you would otherwise have. So huge, huge changes in miscarriage, 50% increase in your miscarriage rate. When they looked at this in terms of your own versus donor, 7% for your own per 5-unit increase, and 6% if it was a donor. So that part didn't really change, whether it was the donor or the autologous, the patient's own eggs. And what that means, which is critically important, is this is not an egg issue, because even with the donor eggs, we're seeing the same impact. This is a problem with either the hormonal milieu or your endometrium that is being impacted by whatever impact the body mass index has. Now, somebody asked, again, very astutely, great question, and kudos to you. What happens if your weight is on the thin side? And we actually had someone that reported that her body mass index was only 15. So first of all, if your body mass index is 15, technically speaking, you're anorexic. And I don't mean you have the eating disorder, although that might be the case. But what I mean is that category is called anorexic. So that is way too low. You are putting a huge strain on your heart, your kidneys, your adrenal glands. That is completely unsafe for anybody to be struggling with. You actually need to get immediate help if your body mass index is that low. And we know, and I've presented this before and talked about it many times, that if your body mass index is lower than 18.5, which is the lower limit of normal for normal body mass index, that those patients don't do as well. In fact, we find even when they're under sort of 20, 21, it's harder to get those patients pregnant. So if your body mass index is very low, number one, you need to seek medical attention, because that could be important for your overall health. Number two, it's going to reduce your success rates. And number three, and we didn't put the chart up because it's kind of hard to see with the graph that they had in this article, but they actually had what's called a J-shaped curve. And what that means is that when your body mass index was very low for miscarriage rates in particular, the miscarriage rates when your body mass index went low also went up, and then they went up quite considerably when your body mass index is higher. So there is a sweet spot in terms of your weight where too thin is not good and too heavy is not good. When you're in that normal range, you're going to get the best chances in terms of reducing your miscarriage rate. So the fact or fiction this week was, can we accurately predict what kind of an impact your body mass index will have? And based on almost 1 million cycles worth of data, we can. We can predict it right down to the number, and you can find out your own category based on your body mass index and adjust with these numbers to be able to tell you exactly where you're going to fit. Now, we didn't incorporate this into our just recent video called Embryo Math, and you'll find that again right up there on the link on our YouTube channel, where we break down bit by bit how you get from deciding you want to do IVF to what you should expect in terms of your success rates, because this wasn't even available when I started the process for that video. But this can be included into that calculus, and you can do it on your own with the data we've provided you here. This video will be up on our YouTube channel shortly, and so you guys will be able to see it there and reference it if you need to. So it is a fact, no question, that the body mass index can actually help you predict both your clinical pregnancy rate, your live birth rate, and your miscarriage risks. And for those of you who are struggling with it, it is not fair for people to tell you to just go lose weight. Any fertility center worth their salt will definitely say to you, we can work with you, we can offer you options, we can help you along the process, we're there to support you through it, and we do that. We have a nutritionist here. I talk to my patients about an appropriate healthy diet. We don't talk about dieting because I don't like telling people they need to go on a diet. We talk about eating healthy. We talk about exercise regimens and how to do that. And those are all critical elements of this. I never tell someone just go lose weight. We talk to patients about what their risks are, how it's going to impact their success rates, and what we can do with them along the way to support them on that sort of process to get them to a point where we optimize and maximize their success rates. So if we can help you, don't hesitate, reach out to us. We will. That's what we're all about. So thank you for joining us for this exciting Fact or Fiction. And again, we always love suggestions. So if you have an idea you want us to bring up on a topic for next week, don't hesitate, send us an idea and we will definitely bring that up. Don't forget to give me some ideas for Valentine's Day. And thank you all for joining us. We're going to start the live question segment, and we do have lots of questions that were asked in advance. So Tarek's going to read them out, and I'm going to answer.
So this one was from YouTube. When doing ICSI, do all oocytes that were retrieved still get fertilized? It's just a more direct method, or is it one of the best sperms and the one of the best oocytes resulting in one embryo?
Oocytes.
Oocytes.
Yeah.
It's still going. For some reason, this is what I previously thought, but I may have been mistaken. And if both methods use all oocytes to create multiple embryos and ICSI is more successful, why is the classic IVF still an option? And are there benefits to doing IVF over ICSI?
It's a long
Was there a
question.
massive cost difference? And when it comes to government funding in Ontario, does the government only cover IVF, or is ICSI also funded under the IVF funding?
Okay, that's a huge question. So I'll try and address that all in one fell swoop. So just so everybody knows, there are two ways to do IVF. One is to do conventional IVF, where you take the egg, you pour in some sperm, and you leave it overnight, and you find it in the morning and pray that it's fertilized. And the second way is to do ICSI, where you pick the best sperm one by one, you take that sperm and you inject it into each egg, and then you take the egg and you hope that that fertilizes. So when you look at studies, and this is in our Embryo Math video, traditionally the success rates are around 50 to 60% for conventional and 60 to 70% for ICSI. If you're working in a center that has really good success rates, you can get much higher. So Dr. Khosravi, our embryologist, is averaging over 90%. And traditionally, she's getting about 100% on almost every case for us. So she has amazing ICSI skills and does a very, very good job. So number one, you can get a higher chance of fertilization with ICSI than you can with conventional. Does that translate into a higher rate of live birth? Well, the studies actually don't support that, but the studies are all based on evidence where they're only getting 70% fertilization. So there aren't a lot of studies looking at 90% fertilization or 100% fertilization. So it's hard to know if you actually are getting an increase in live birth. Is it more expensive? Well, I don't like doing sort of, car sales. when I'm doing IVF. So we just bundle all of our expenses in one cost. So we don't talk to patients about this much for this and that much for that. We just have, here's everything you need as part of your IVF except for your meds. This is what it costs. And that includes everything from high to the actual freezing and maintenance of your embryos for 1 year and everything in between. So as part of that package, we always include ICSI. When you're doing the Ontario government funding program, for those of you that are in Ontario, it is covered. So if you insist that the center use ICSI, they do have to do it and they cannot charge you extra for ICSI. It is part of the funding program, so they can't charge extra for that. They can charge you extra for doing genetic testing. That's a separate issue altogether, but they can't charge you extra for doing the ICSI. It's covered. So hopefully that answers all your questions. It's not necessarily going to improve your success rates, but it very much depends on who's doing the ICSI, how the ICSI was done, when it was done, how careful they are, and so on. So if they're getting, 100% fertilization or 90% or greater fertilization, you're likely going to see an improvement in outcome because you just can't achieve anywhere close to that with conventional IVF, no matter how good the center is.
Hi, Dr. Victor. I'm 36, male, and I have a decent SA result, everything within normal limits. But I was worried about the 20% abnormal morphology. I was wondering if I should do a DNA fragments test to ensure I have high sperm quality. Thanks.
Yeah, so that's a great question. So congratulations, you actually sound like you have a very normal semen analysis. So 20% abnormal is actually normal. Depending on which criteria you use, and most of us use the World Health Organization criteria, you actually only need 4% of the sperm to be normal, but that's by something called strict criteria where they really carefully have to analyze the sperm. So under those circumstances, you typically will get very normal fertilization and pregnancy results as long as you have a reasonable number of normal sperm. And if only 20% of your sperm are abnormal, it means you've got 80% normal, so you're well above the 4% that you need. So if your count's good, your motility is good, your progression, which is how fast they're going, is good, and the number of abnormal forms is within reason, then you should have a good outcome. Now, DNA fragmentation is a different issue, and it's controversial still, but I'm going to touch on that. So we do have a video on it from several months ago, probably almost a year ago now. And we can put the link up for that in this video as well. I'm going to have Tarek working triple overtime, finding links and putting them in these videos. But the reality is that if you believe in DNA fragmentation, here's what the data shows. We know for sure that if you have high DNA fragmentation, your miscarriage rate is much, much higher, as high as 12 times higher. We also know that if your DNA fragmentation is high, there is a suggestion, not fully proven, but believed, that fertilization, embryo development, and implantation are compromised. So I'm a believer in that, but the data is not 100% there yet. I think we just need more studies and we'll be able to prove that. So is it worth doing DNA fragmentation before you do IVF? I believe it is. Of course, it depends on what they're charging you for it. We're only charging $200, so we're pretty inexpensive for our DNA fragmentation, but I do know that some centers charge a lot more. And so, at that rate, if we can get a good answer for you and help correct the DNA fragmentation before you go into your IVF cycle, that's a great idea, and I'm a believer for doing that. So should you? Yes. Now, some people wonder, is there a way to predict if their DNA fragmentation is high from their semen analysis so that they can kind of judge, do I really need to do the test? And the answer to that is no, there isn't. So I just got off the phone today with a gentleman who had great semen analysis. The sperm was quite normal, but his sperm DNA fragmentation was terrible. And I actually don't have an explanation for it. He doesn't have bad habits. He's not in bad shape. He's a healthy guy. Everything was normal. But at the same time, we just weren't getting, the kinds of results that we wanted. So I believe in doing it because it's really a very small extra charge if you're going for IVF. So yeah, I mean, if you're watching and you're wanting to know if your sperm is going to be useful, get the DNA frag. It's an incremental cost, and it'll give you a lot of information.
Can you get me your phone?
Yeah, of course.
All right, so one of the questions we can start with.
We're still good?
Oh yeah. 2 centimeter SCH. Would you stop fragment
Yeah.
MTHFR and PAI
Positive.
1 4G heterogeneous 6W3D?
Wow. That's a really tough one. So the question is, there was a lot of terminology there. So the question is, if you have a subchorionic hemorrhage, should you stop the things that are anticoagulating you, in particular when you have things that are procoagulant, like methyl tetrahydrofolate reductase enzyme deficiency and plasminogen activator inhibitor? So that's tough. There's no data to answer that question. My response would be I'd probably stay on either the aspirin or the heparin, especially if it's only 2 centimeters, but it really depends on how much you're bleeding. Typically, subchorionic hemorrhages will resolve, but they don't always. And can it cause a miscarriage? Yes, it can. So you can either go off both for a short period of time, wait for everything to resolve, and then go back on, or you stay on one of the two. I wouldn't stay on both. That's probably a lot of anticoagulation for someone with a subchorionic hemorrhage. Traditionally with us, if you have an SCH, we'll actually stop all your anticoagulants. But in your case, with kind of a thrombophilia tendency, I would be cautious. So maybe stay on the aspirin, go off the heparin, or stay on the heparin and go off the aspirin. And then do it for a short period of time, make sure the bleeding resolves, and then you can discuss it with your OB.
Does abnormal sperm morphology mean infertility for a man?
It can. I mean, certainly if you have very high sperm morphology numbers, like the 4% I just mentioned earlier, it does decrease your chances of success. So the World Health Organization specified that based on looking at thousands and thousands of men and analyzing the time it took them to get pregnant with their partners, and then looking at their sperm analyses and determining what the relationship was. So when their sperm morphology was low, they had a harder time conceiving with their partners. So yeah, it can. If your sperm morphology is very poor, it can affect things. And keep in mind that if your sperm morphology is very high, you may have higher DNA fragmentation, which again has an impact.
What to do before and after egg retrieval?
Before, stay calm, stay away from everything bad. No smoking, no drinking, no drug use. Take lots of vitamins, meditate, pray, exercise, stay in good shape. Avoid extremes of anything, whether it's temperature or sugar or cholesterol. So it's probably the wrong time to dive into poutine. Just kind of stay natural and healthy. After, rest. Try not to jump around too much. I definitely would avoid intercourse for a couple of days, and stay with those healthy habits. We don't want you plowing into a bottle of wine because you're finally done. That still has lasting impact on your other eggs and on your endometrium and your uterus, not to mention your cancer risks. So yeah, just be healthy before and after, and do anything that helps you stay calm.
How do you manage a case of PCOD with thin endometrium for a natural cycle or an IUI?
There are loads of ways to manage thin PCOS or thin lining with someone that's got PCOS. Lots of different ways. So you can use letrozole, you can give them estrogen. If you really need to, you could use Viagra. Vitamin C, D, and E have been shown to be beneficial. You could use shots if you have to, although we try to avoid that because we want to keep the estrogen levels low. And you can give estrogen. So that's a really simple thing to manage. It's not difficult at all. Just talk to your fertility specialist and they can adjust that.
Called your office for an appointment. Are there current U.S. Canadian travel restrictions?
Yes. So there are U.S. Canadian travel restrictions and Canadian U.S. travel restrictions. So I can't go to my cottage in the States, which is driving me crazy. But the reality is that if you're coming to Canada from outside Canada, you now need to quarantine in a hotel until you get the results of your COVID test. And they are charging a fortune for staying in the hotel. It's apparently $600 per day. And then after 3 days, when you've got your COVID test results, assuming they get them to you in 3 days, you then can go out, and I believe you no longer need to quarantine, but don't quote me on that because this is brand new. So there are restrictions on being able to come and go. I think those restrictions are designed to dissuade people from coming in and out of the country, including Canadians leaving and coming back. So right now is not a great time to travel. We'd be happy to take care of you. Unfortunately, this pandemic is putting a kink in the works. But I have friends that work in the US. I have no financial relationship with any of them whatsoever. And I can definitely refer you to some different colleagues around the country who I trust and feel very comfortable with. There's the San Diego Fertility Center. There is the Utah Fertility Center. There's Northwestern with Eve Feinberg. She's incredible, one of the smartest people I know. So there are some fertility centers out there that we really trust. And if you need to use any of those centers, let me know and I'll hook you up with the right people.
2 centimeter SCH. Is bed rest necessary?
That's probably from the same person. Yeah, so that's a great question. So someone with a 2 centimeter subchorionic hemorrhage, should they be in bed? So they have done studies of this and it actually doesn't show a benefit. Having said that, would I get up and run around? No. Should you avoid anything that causes strain or heavy lifting? Yes. And so, you know, I would take it easy. The bigger issue with it actually is not so much medical, it's psychological. So God forbid, if you do go out and do things and you go on and miscarry, you will forever think that it was something that you did. Whereas if you stay relatively calm, and I'm not saying the Mrs. Doubtfire scene, you know, where she's like this, or Robin Williams is like this, doing nothing, not moving, you know, you don't need to do that. I don't need you to become a mummy instead of a mommy. But you don't want to be running around either. So if you're kind of chilling at home, you know, put your feet up, watch Netflix, as I always like to say to my patients, then you'll at least not regret it. So do whatever relaxes you the most, but definitely nothing high impact, no heavy lifting, no straining, avoid intercourse, definitely no smoking, no drinking, no drug use, that kind of thing for sure.
Is surgery for embolization better for versus
For what? Let me see it.
getting out of hand.
Is surgery or embolization better for a varicocele? Yeah, that's a great question. I'm not sure if there's any studies on that. There probably is, and maybe we can look that up together. That might be a good fact or fiction. But I will tell you this. When they embolize, they use these things called polyvinyl alcohol particles. So there's these tiny little spheres. And what happens is these things don't dissolve or absorb. They go and they literally plug the blood vessels. So they just pile up on top of one another. It's like throwing, you know, a million marbles into a drain. Eventually, if they all land in exactly the right place, they won't go through. So that's exactly the process that's used to plug blood vessels. So the problem with doing it is, like the marble analogy, some of them are going to get through the drain. And when they do, they go in and they actually land in the tissue. So if you ever ultrasound the scrotum of a guy that has had this done, it lights up like a Christmas tree. There's all these little spots of white all over the testicle where it's blocked. Well, that's definitely going to damage the testicle. There's no question. So I actually refuse to embolize any of my patients. We always recommend the surgery because I have seen guys that got the embolization and then they went into testicular failure. And we know from women that women who are older who got uterine artery embolizations for fibroids in their uterus, and by older I'm only talking about over the age of 35, so all due respect to those of you, but in the studies they referred to them as older. So when they did that, there was a much higher preponderance of women that went into premature menopause. And they realized it was because some of these polyvinyl alcohol particles were floating into the ovarian blood supply and actually blocking the blood supply to the ovary or the blood supply within the ovary. So don't embolize if you're trying to get pregnant. Don't get a uterine fibroid embolization. Definitely don't get a uterine artery embolization, and don't get the varicocele embolizations either.
Cyst 13 millimeter remains from December. Waiting for FET. Estro down 170 to 106. What now?
Nothing. A 13 millimeter cyst is not a cyst. It's an egg. So we wouldn't even pay attention to that. And your estrogen sounds normal. So that's perfectly fine. Fire ahead.
What makes a good candidate or eligible surrogate?
Ooh, great question. Nice, friendly, sane, not in it purely for the money, healthy, no major medical problems, no personal history of complicated fertility or pregnancies, hypertension, diabetes, bleeding, abruptions, preterm labor, that kind of thing. Body mass index is important, so they need to have a reasonable body mass index, a minimum of under 35. And they must be someone that does not smoke, drink, or use drugs at all, like zero. So those are the major qualifications. You got to get along with them because you do need to know your surrogate. They're carrying your baby and they're carrying it for you, so it's got to be a good relationship. And obviously look for someone that is doing it out of the goodness of their hearts rather than for other motivations. Good question.
Do you recommend ERA test before FET? What can patients do to prepare for their FET?
I hate the ERA test. So most of you that watch this show know that I have presented on that already. We presented iGenomics' own data on the ERA, which demonstrates that it is useless in their own study. And there are 2 new studies that are out. I was actually going to do that tonight, but I decided to do this one instead. Maybe I'll do it next week. And I wanted to name it Nailing the Coffin Closed on the ERA test. So the ERA test in 2 new studies has also been proven to be useless. So do not bother with an ERA test. I just spoke with a lovely couple from New Jersey for about an hour tonight about their fertility journey. They did the ERA test and I told them to abandon the ERA test. It makes absolutely no difference, guys. Do not do it. It's a waste of time.
Is a fresh transfer or a frozen transfer better if given the choice?
So we've got 2 videos on that, links here and there. And Tariq, again, he's cringing over here. So we've got one on whether it's safer for the pregnancy, and we've got another one on the success rate. So overall, with most women who are producing a relatively high number of eggs, it's both safer and more successful if you're doing frozen. If you're producing a lower number of eggs, or you are older, then it may be reasonable to do a fresh. So it depends on lots of the dynamics. It's not a thing, again, you have to individualize. So make sure your center knows how to deal with you specifically rather than just kind of a global approach to this. And also keep in mind that frequently your low egg yield, which would make you a better candidate for doing a fresh transfer, can translate into older age, which means you may need genetic testing of your embryos, and that can't be done fresh. So it's sometimes difficult, even when you qualify to get a fresh transfer, to actually do a fresh transfer because you may need to do the genetic testing.
Could an ovarian septum grow back after having surgery in 2015 and 2 babies?
An ovarian septum or a uterine septum? There's no such thing as an ovarian septum. Maybe they meant uterine septum.
I just read the questions there. I try and read the question.
Tariq is putting out his innocence disclaimer here, guys. So yeah, I think you mean uterine septum, and the answer is it's very rare. I have seen some patients where I resected them, they got pregnant, they came back for their next test, for their next baby, and it was more prominent again. It can't really grow back, but I guess biology is biology, anything's possible. So typically it certainly wouldn't come back in full, but it may be more pronounced again. It's possible, but there's no such thing as an ovarian septum. So I'm assuming you mean uterine septum inside the uterus. And for those of you that don't know what that is, it's when the inside of the uterus is indented kind of sharply down, and it can be a little bit or it can be a lot. It can go all the way down to the cervix.
Hi, Dr. V. What is protocol for high baseline E2 and low FSH?
So it depends on why you're like that. If your E2 is high and your FSH is low, we would be looking for a cyst. So we kind of need to know what's wrong. And then once we figure out what's wrong, we can determine what to do. So if it's a cyst, you would wait or drain the cyst, or if you need surgery, have surgery. If it's because your ovary is beginning to get tired or weak, that's a different story. So then we look at protocols that engage women with diminished ovarian reserve, and there are loads of different protocols for that. So there's a letrozole protocol, there's estrogen priming, testosterone priming. Some people like DHEA, which has not been proven to be beneficial for live birth, nor has estrogen priming for that matter. Some people use an antagonist protocol. I use the microdose flare protocol with Lupron. But microdoses, so that's shown reasonable results for us. So any of these things can be used and are very effective. Whether or not you fit one or the other, they've all been tested and they've all been compared to one another, and there is no difference between any of them. So whatever works for you is great. We can try that out and see what we get.
I was told by my nurse to stop taking aspirin 5 days before retrieval. When is a good time to start taking it again? And if it is a successful pregnancy, when could be a good time to be stopped?
Okay, so I'm not sure where you were doing that. So we don't actually stop aspirin if we need a patient on it prior to a retrieval, but we don't necessarily always put people on aspirin prior to retrieval. So aspirin affects your platelet function. That's actually how it thins out your blood. It prevents platelets from sticking together, which is how platelets work to help you stop bleeding. And the answer from all of that is that it actually blocks them for 21 days. So stopping 5 days in advance does nothing. So I'm not sure why you're stopping 5 days in advance. That may have been an error, and maybe just have a chat with your nurse about that. As far as pregnancy or embryo implantation goes, if you're doing IVF, so we actually start it before your embryo goes in, and I actually tell patients to stay on it right up until they deliver. So in our practice, we keep our patients on aspirin. We do have another fact or fiction on the benefits of aspirin. The link is right there.
Is it?
And the aspirin video shows that there is a decrease in preterm labor, and we are pretty sure it decreases preeclampsia too. So there's lots of different options, but use aspirin throughout the pregnancy. It's probably beneficial for a variety of things.
I'm wondering if it's safe to continue taking uniquinol after a transfer. I've heard different opinions from my fertility doctor and naturopath. Yeah,
ubiquinol's fine. There's no evidence one way or another, so you can stay on it.
Hi, doctor. Thanks for this opportunity you give us to ask questions.
You're welcome. Thanks for being here to ask. We love doing this show. Tarek and I have a great time every week. Thank you for following. Huge shout out to all of you guys. Thanks for watching our YouTube videos. We're growing really quickly on YouTube. One of our videos now has 22,000 views as of today. That's our COVID vaccine one. And yeah, we love growing. So if you have friends and they are looking for help, make sure you tell them to follow us on Instagram and on YouTube and on Facebook. We're happy to help out any way we can.
Hi, Dr. Victory. I have PCOS and lost 7 kilograms over the last 2 months.
Awesome.
However, consequently, have been having my period delayed more than usual. Could this be due to the weight loss?
It could, or you could be pregnant. So get a beta HCG test. Any sudden change in weight can impact your hormones. So your period may take longer, but if you're PCO, make sure that your periods are coming because of ovulation. So a number of women with PCO get bleeds just because the lining gets so thick that it becomes unstable and it sheds. That is not a period in the sense of an egg coming and progesterone going up and coming down. Which is necessary in order to get rid of the lining entirely. If that's not happening for you, you are accumulating abnormal cells inside your uterus, and sooner or later it can become precancerous or cancerous. So the length of your cycle isn't so much important as much as ovulation is. So make sure you're ovulating either by checking your progesterone or doing the ovulation predictor kits or monitoring with ultrasound, whatever way you want to do it. But there's got to be a way to monitor you to make sure you're having ovulatory cycles. If you're not, you need to get on meds or supplements to correct that.
You need a Lambo on the wall.
I got a Lambo on the wall. I love you guys. So the new one is a Lambo, and it's a unique model too. And I opened the doors, and it's a really nice blue color too. I love that Lambo. I would love to own that Lambo. They look and they sound awesome. So that's my first Lambo, and we've got 2 on order. There's a Mercedes coming. What was the other one we got? Another Lambo. Oh, we got the remote control ones. We got some new cars coming. Yeah, I know. My Ferrari 488 Italia Pista fell off the wall. So the Velcro did not hang on, so we got to do that one again.
Is it safe to take Fertile Pro LQ plus Reversatol and Fertile Pro Fems plus Reishi while taking Synthroid? Who makes these names?
Yeah, you can take all those while taking Synthroid. That's not a problem. I wouldn't take them at exactly the same time, but you can take them together, just not together. So normally when you're taking any thyroid medication, they ask you to separate it from anything else you take for at least half an hour.
Does PGTA overrule embryo grading? Should I worry about success rates of 4BB PGTA embryo at age 36?
Nope. So they actually did a recent study which showed that your embryo grade was not relevant if you had PGA tested embryos unless they were below a certain threshold, and it's below BB. So if you're like C grade and lower, then yes, it has an impact. But if you're BC or BB and higher, it's fine. So you don't need to pay any attention to the grading if you're PGTA tested and normal.
What sperm count is considered low for IUI?
So we reviewed that on another fertility factor fiction. So 14 million has a reasonable success rate. If you're lower than 5 million, your success rate, this is in your final count, your success rate does start to drop off. There is still a success rate, but it's low.
What is considered a good sperm count post-wash for an IUI transfer? Is 10 million post-wash, 100% being motile level 4 considered good?
Yeah, that's pretty decent. Again, that article I'm referencing in the Factor Fiction video we had showed 14. That was their cutoff, but 10 million is pretty close, and that's a good number. And traditionally, we actually used to use 10 million as the number, so I'm comfortable with 10 million.
Is embryo grading, AA, AB, etc., genetic testing, is that done in Ontario as well?
So embryo grading is done everywhere, pretty much worldwide. Everybody grades their embryos. So when you're looking at an embryo grade, they are talking about the stage of the blastocyst. They're talking about the blastocele, which is the portion of the embryo that is going to become the baby. And then they're talking about the trophectoderm, which is the portion that's going to become the placenta. So the first letter is for the baby part and the second letter is for the placenta part. So you are getting graded everywhere. Genetic testing is not necessarily done everywhere. There are some countries where it's very difficult to get genetic testing done, and other countries where they are doing it. But overall, you can get that done in Canada for sure, and we offer it pretty much everywhere. We do it for our patients who are over the age of 38. Under the age of 38, there's no benefit, so we don't do it for those patients.
Is there any BMI at which you would refuse treatment?
Yeah, so certainly over 40, the chances are much, much lower, and we do not recommend that you try. Plus, there's difficulty with success in terms of the outcomes, as I showed you tonight. And then on top of that, we're not really supposed to use conscious sedation on patients with a BMI over 40 because you run into trouble with the anesthetic component of things, and that starts making them a higher risk category. We're not really supposed to take high risk category patients in the out of hospital premises program. So we won't do it when you're over 40. If you look on our website, we have a resource guide. And in the resource guide, there is a whole section on the impact of BMI and fertility. And we developed this about a year and a half ago.
Yeah.
And it's beautifully done. Tarek had one of his guys do this beautiful job on it. So there's a short version and a long version. I do recommend you download the long version. And it's a beautiful kind of PDF of all of the risks. It goes into great detail. I spent over a month developing that for you guys. Spend some time on that and check it out. It is actually very, very significant and actually concerning how high the risks are when your body mass index gets higher than even 35, let alone 40.
Hi, Dr. V. Can your lining be too thick?
Yes.
What happens to IOS success rates if the lining is greater than 13 millimeters? Thank you again for spreading your wealth of knowledge weekly with all of us. Such an intelligent man and team. Really appreciate you guys.
Well, thank you for complimenting the team. I'm all about the team, so I appreciate that. And thank you for watching again. So with IUI, we don't really pay attention to the endometrial thickness because there's not really anything you can do. So we don't, try and adjust endometrial thickness for IUI. And to the best of my knowledge, no one does try to adjust endometrial thickness for IUI. It would actually be relatively difficult to do because you can't really adjust the estrogen level. You're just getting what your body is making. You could maybe bounce around the progesterone level a little bit to try and thin it out more if it was too thick. Having said that, we do know with IVF that it can be too thick, so we don't want it too thick. So if you're getting a really thick lining with your IUIs, then hindsight's 20/20, and what I mean by that is you learn from the first one and do less stimulation the second time around so that you don't get as thick a lining, or you use an agent which you know won't give you as thick a lining. For example, Clomid tends to thin your lining because it's relatively anti-estrogenic in the uterus. So you get thin lining but more eggs. So that might be a good approach for someone that's making a naturally thicker lining.
Hi, Dr. Victory. Thank you for making these videos. Is it true that CoQ10 could help with recurrent miscarriages? Do you recommend to continue taking it during pregnancy?
I do recommend taking it during pregnancy because it's harmless. I'm not aware of any data that says that CoQ10 reduces miscarriages. So that's something that would need to be looked at. Maybe I'll check that out. We should have a look at that, maybe make a note of that. But I'm not aware of data that says that CoQ10 reduces miscarriages. So that's probably not something that's either being looked at or published. But I'll check it out for you. We'll let you know. Interesting idea.
Serious question.
Serious question.
Hi. Do you alter IVF FET treatments for homogeneous MTHFR patients? I am homogeneous for the C677T variant, also AMA plus, TCH 2.97. Is this TSH too high? Do I need heparin, Levodopa? Thanks.
Okay, so I love these coded messages. Yeah, the jargon is pretty impressive. Okay, so we do alter the FET protocol if you have multiple thrombophilias. So we will add heparin into protocols like that, or a low molecular weight heparin into a protocol like that on top of the aspirin that we always use for all of our FETs. So we do use aspirin for all of our FETs because of the proven benefits. But we would add in Levodopa if you had multiple things. 2.9 is too high for your TSH. It's supposed to be less than 2.5. So I would bring that down a little bit. And I think that answered both questions.
Sometimes I struggle to read.
Tarek's going to need to get a medical degree just to read these.
38-year-old DXW PCOS.
DXW?
DXW, yeah.
Okay. DXW
PCOS Hashimoto's 5'5", 198 pounds. 2 children over 18 years ago, period that lasts 30 plus days, X 3 years, take Provera to stop it, would weight loss help regulate so then we can try and get pregnant naturally?
Yeah, so make sure your Hashimoto's is treated. Make sure that your PCOS is treated. If your cycles are not ovulatory, like I said, that is dangerous. So that has to be addressed. It must be addressed. We have an Instagram post on that a while back, clearly demonstrating that women with PCOS are much, much higher risk of multiple health outcomes, all of which are very risky, including heart disease, diabetes, metabolic syndrome, depression, anxiety, and cancer of the uterus, possibly cancer of the breast. So you got to be ovulatory. In order to achieve that, yes, you need to bring down the weight. 5'5", 198 would give you a high BMI, so bringing that down is very critical for you. And there are medical ways to do that as well. Metformin, letrozole, supplements, inositol, NAC, coenzyme Q10, the omega-3 fatty acids or DHA. And then on top of that, lifestyle choices. So daily exercise with HIIT training, HIIT, high intensity interval training, muscle building, some cardio, and then a healthy, balanced diet, less than 1,500 calories per day, over 6 meals, breakfast, snack, lunch, snack, dinner, snack.
Can you explain the big difference between the 2 sperm washes you guys perform and the success rates much greater with the newer process?
Yeah. So we have 2 techniques. We have the traditional technique, which was the spin. So you put a gradient, it's actually 2 levels of gradient, into a centrifuge tube. You pour the ejaculate on top, you spin it around a gajillion miles an hour, and then you take the pellet at the bottom of the gradient, you resuspend that in something called sperm wash, which is like Red Bull for sperm, and then you spin it at 1,000,000 miles an hour again and take that pellet and resuspend it in more of the Red Bull, and that's what we use to inject into you. So the benefit of doing that is even with a low sperm number, you can still get a decent amount at the end. The disadvantage of doing that is that it actually increases the amount of sperm DNA fragmentation. So if you're low, you're probably okay, but if you're high, it's not good for the sperm. The alternative method is to use this new device from a company called Zymo, Z-Y-M-O-T. I don't work for them. I have nothing to do with that. But they have this great little device where you kind of insert the ejaculate on one port, and then the ejaculate goes under this membrane. You pour media on the top, and the sperm swim through to get into the media. They got to go through this membrane. It actually stops or prevents a lot of bad sperm from getting through and results in a 90% reduction in the sperm with high DNA fragmentation from getting through. And then you just take it from the other port, it's called the outlet port, and that's what we use to inject. So we implemented this and saw a very substantial improvement in our success rates. So we use it. You know, it is quite remarkable. It does add a little bit to the cost, but in my mind, it's worth it because you're reducing miscarriage rates, you're reducing the complications, you're improving the chances. It doesn't work for everybody though. If your sperm is very slow, not enough of them will get through. They got to be strong enough to swim through the membrane. So it's not for everybody, but it does work well. For the patients that qualify for it, it's a good thing.
859.
You can ask a couple more.
Yeah, I will. I'm just letting you know. How permanent is a low AMH result, and how accurate is it in predicting onset of menopause?
So AMH is very accurate in predicting the onset of menopause, and it's pretty accurate in terms of being repeatable, unless there's something else going on. So there are factors that can interact with your AMH, but once you've got a low AMH, generally speaking, you're going to maintain a low AMH. So yeah, get it checked again if you want to, but you got to hustle in terms of fertility therapy if your AMH is going low. And it is very accurate once you fall below a certain threshold, depending on which units you're using, in terms of prediction of menopause, actually down to within months. And there's a study on that.
When doing ICSI, are all eggs fertilized that are retrieved or just one?
Oh, forgot to answer that earlier. They asked that. Sorry. Okay, so when we do ICSI, when we do IVF, we retrieve all of the eggs we can see, unless you're doing duostim, because then you leave some of the smaller ones so that they grow. But in any other circumstance, you get all of the eggs that you can see, especially if it's someone with PCO, because you want to catch them all, because the leftover eggs cause lots of pain and pressure and bloating and fluid and so on. So we get out all the eggs. The ones that we fertilize are the ones that achieve a certain maturity stage called M2, and at that stage we are able to fertilize them. So we fertilize all of your M2 eggs. We don't fertilize the ones that are not M2. Occasionally we'll try to mature some of the ones that are not M2. And my last embryologist that I worked with used to do something he called embedding, but it never really worked very well. So he would inject them even when they were not yet M2, hoping that they would become M2 and then fertilize with the sperm already there. But it very rarely worked for us at all. And I don't think we actually had any pregnancies from those specific ones. So we wait for them to mature, and if they're not mature, we don't do anything with them. So anything that is mature gets ICSI, anything that is not mature doesn't.
36-year-old with PCOS, just had an early miscarriage. When do you recommend, is it safe to try again?
Immediately. You don't have to wait if you have had a miscarriage. There was a good study that looked at that a while back, probably 2 years ago now, and they examined people that waited versus women that didn't wait and tried right away. Once you've had another period, you're safe to go ahead and try. There's no benefit to waiting whatsoever.
I'm currently a patient of yours and have been thinking about IVF. What is the timeline from start to finish for the whole process?
So it depends on which category you fall into in terms of are we doing a frozen or a fresh. So from the time you say go till the time we actually do your retrieval, you're usually looking at somewhere between 4 to 6 weeks. And if you need to do a frozen transfer, then another sort of 4 to 6 weeks, even up to 8 weeks to get you ready for that, especially if it's more complicated where we need to do genetic testing or PGT and so on. If you're getting a fresh transfer for whatever reason, it would be kind of right within that 4 to 6 week window.
Do you have a feeling about the effect of low testosterone on follicle development and outcomes for IVF?
Yeah, I don't need to have a feeling. There's actually good data that shows that it reduces the success rate. So there's lots of data on testosterone levels in relation to outcomes, and they have shown that testosterone is one of the few things that actually can predict the outcome of your IVF cycle. There is one study that shows that pre-treatment with testosterone actually does increase live birth rates. So that's why we do testosterone priming if we're going to help someone make more eggs.
Hello, Dr. Victory. After miscarriage, when will the next full period normally will come? Recently, I feel painful around my right breast, shoulder, and back. Is that could be a symptom of PCOS?
Wow. So 4 to 6 weeks normally for your period to come back. Breast, chest, and shoulder pain have nothing to do with PCOS at all. So if you're having breast, chest, and shoulder pain, you need to go get checked out for a blood clot. Go see your doctor right away, please. It's got nothing to do with PCOS. Zero.
Is leucospermia detectable with semen analysis?
Yep.
Could that be a major factor for low sperm count and motility? Should it be treated before future IUI?
Yeah, for sure. If you have a lot of white blood cells, if we see white blood cells, we typically treat the patients with antibiotics. That's what leucospermia is. It's the presence of white blood cells in the sperm. So if we see that, we tend to treat them with antibiotics and recheck. You can't always get rid of it completely, but we do try to reduce it as much as possible. And yes, it should be treated prior to IUI for sure.
Sorry if this is outside the scope of fertility, but struggling to find a good resource for the latest literature on cord blood banking. How useful is it possible with preterm birth?
Yeah, so it is possible with preterm birth. You may not get as much blood. And with preemies, there is a benefit to delayed cord clamping or milking the cord into them. That benefit probably outweighs the benefits of doing cord blood collection. I am a believer in cord blood collection to a point. So we do sign up all of our women for it, just because there's a medical legal reason for that, and that is that somebody actually got sued for not telling their obstetrical patient about it, and then they sued the OB for not telling them. So we just automatically sign up everybody and then let them choose once they've heard the information. Having said that, there is a lot of data now demonstrating that stem cell therapy in general can be beneficial for a variety of conditions, and they learn more about how to use it and who to use it in every single day. So I'm a believer in it. I couldn't afford it when I was having my children because my wife and I got started early in life. My kids are more my buddies now than they are my children. But the reality is that if I could have afforded it, like if I was doing it now, I would unhesitatingly do the cord blood collection. Back then, we really didn't know that much about it, and so I didn't do it because we really didn't know what it was useful for, and it was expensive. But nowadays, it's pretty reasonable. It's manageable for most people, and if you can afford it, do it for sure.
I take birth control for hormone support, emulating menstrual cycle due to PCOS. I became pregnant via donor egg. What medication or natural remedies can I take for hormone support?
You don't need hormone support if you're pregnant because your placenta is taking over and making everything. So you don't need any hormone support once you're pregnant. So if you mean while you're pregnant, you don't need anything after the first 6 or 12 weeks. If you mean after the pregnancy, if you're breastfeeding, you still shouldn't need anything. After that, you should go back on the birth control pill.
Do you have recommendations for post-transfer and exercise, especially if someone does a lot pre-transfer?
So I actually wouldn't recommend you do a lot pre-transfer. I would recommend you do a little bit pre-transfer, just enough to keep your stress low. You don't want to distract blood flow away from your uterus. And after, very, very little, like super gentle, nothing exciting, keep it reasonably low.
What is the difference in starting Femera on cycle day 3-7 versus 5-9?
There's no data to show that there's a significant difference between 3-7 or 5-9 for Femera. There is a comparison for Clomid, and they actually showed that 3-7 was better than 5-9. So we always do 3-7. But for Femera, there's no real data, and it's always been 3-7. So we don't even try using Femera any other days. Are we going on forever? 9:15? What do you want? What's the goal?
I don't know. You can't catch up.
Okay, we'll go for another 7 minutes, guys.
Why might an egg retrieval be canceled? Would you cancel it if there wasn't a certain amount of follicles? How many is not enough?
Yeah, that's a fantastic question. So thanks for asking that. It's not so much how many is not enough, it's how well are we doing for you. So for example, if we think you're capable of making 12 eggs and you're only making 3, I'm going to cancel you because that's terrible value for you. Now, if you're insured somehow, like you're in the States and you've got insurance, okay, it doesn't matter because if you're doing it multiple times, that's fine. And if somebody else is paying for it, that's great. You're just banking lots of embryos. But here, where people are often paying for it, or if they're going through a government-funded cycle and it's their only chance, I'm not going to mess it up by not doing my very best for you. So if I think you can make 10 or 12 or 15 and you're only producing a fraction of that, we would cancel you. Where's the number? Well, that's something we decide with you. So you might say, look, I'm good with 9 or 10 eggs or 8 eggs because I'm 32 and my chances are 80% at your clinic, and so I'm very comfortable with this, fire ahead. And my response would be, great, let's go for it. But if you're only making 3 eggs and you've got an antral follicle count of 15 or 20, I'm going to say that doesn't make sense. Something went wrong and we should stop. And we try to do that fairly early on in the cycle, although it doesn't always work, but we're really careful about that. So it has to be individualized to the patient. If you're 43 and you are only capable of making 3 eggs and you make 2, I'm going to go and get the 2. If you have diminished ovarian reserve and you're only capable of making one, we do natural cycle IVF all the time. So it all depends on you and on what the goals are and what the understanding is before you start. So you have to have that kind of clearly defined ahead of time, especially for the patients where you're expecting a low number of eggs. For the patients where you're expecting a high number of eggs, if you're getting a low number, it's only fair to that patient to stop because you can do much better for them. The one point where it gets a little tricky is if they've spent a lot of money on meds and they don't have insurance coverage for their meds. So then you got to worry about the fact that potentially you're wasting some of their money because they've spent, you know, $3,000 on meds already, and now you're going to cancel them, or they're going to have to spend another $3,000 on meds. So yeah, I think that's a critical point. And when that happens with us, we do our best to make it up to you by finding donated meds. Sometimes we see if the companies are willing to donate some meds. Doesn't work always, but we try what we can. So we go out of our way for you to kind of level the playing field and make it as cost neutral for you as possible, because we feel for those patients. It's no one's fault. It's not yours. It's not ours, but we want to do our best to try and help you out where we can.
What could be the reason for oral blood spotting during second trimester?
Oral blood spotting? I mean, if you mean bleeding from, I'm not sure what you mean by oral blood spotting. If you mean bleeding from your gums, then it's probably because you get way more blood vessels in your body and way more blood volume in your body. But you do need to be checked to make sure you don't have a platelet disorder. But it's very common to get what's called hyperemia in your gums from pregnancy. So women that floss or brush their teeth a little more aggressively will bleed during pregnancy, and that's common. They get more nosebleeds. That's very, very normal. But if you mean vaginal bleeding, you need to be checked out, especially because we need to know your blood type. So that should be a direct go see your OB and make sure that the bleeding's not coming from your cervix opening or trauma to your cervix or the placenta being too low or anything like that. That's an important thing to get checked out. Last one.
Okay. I find I bruise easily with taking 81 milligrams daily. I find more bruises without explanation. Should I stop taking or keep taking?
If it's just bruising and you're otherwise okay, it's probably all right, but you should probably go get checked out. So I would see your doctor and make sure they check you out, make sure the rest of your blood work's okay, your platelets are still functional, there's not something else going on. Just because you're on aspirin does not mean that you're not developing some other kind of condition. For example, idiopathic thrombocytopenic purpura, or ITP, where your platelets become dysfunctional. If your platelets become dysfunctional, you could be prevented from clotting, and then if you're on aspirin, it's making it worse, and that could actually be dangerous. So you do need to take these things seriously. Always seek the advice of your physician.
What does testosterone priming look like generally in your clinic? A full month or less?
Yeah, we usually do it for a week or two before the cycle, and then through the cycle up until the point where we're doing your egg retrieval. So we don't go too crazy, but it does end up being about a month prior to retrieval. Last one, man.
Okay. Last one.
Pick a good one.
It's the pressure. Okay, here we go.
I'm free of any responsibility here. If Tarek doesn't choose your question, you can all write him scathing remarks.
I think it's going to happen. I think it's going to happen. Okay, here we go.
Yeah.
Okay. I just got to make sure it's a doozy here.
What a build-up and then a letdown, eh, guys?
If a woman was slow to respond to stimulation, but then caught up, stopped meds for 2 days due to overstim, and restarted meds for 2 days, do you still see success? Also, what is the latest cycle day you can perform an IUI?
So yes, we do see success. There are lots of ups and downs and adjustments during any fertility treatment cycle. That's not really a problem at all. And kind of the latest we'll go is like 17, 18 days. If it's going more than 17 or 18 days, I'm starting to feel like it's going too long. Again, it doesn't mean it won't work, but that starts making me nervous about egg quality. Are we good? Are there still like a million questions? A million. Okay, guys, I am post-call, so I was up all night delivering babies, so I am going to respectfully recuse myself from further questioning tonight. Thank you for joining us. We love you guys. If you have questions, you can always send them to us, and I will do my best to answer. And if you didn't get your question answered tonight, I do sincerely apologize. We're toying with some ideas to get your questions asked in advance and then kind of guarantee how to answer them, but it's tough, and I like doing them live so that I'm challenged and you guys get the opportunity to ask. So don't hesitate to join us again next week. Maybe we'll review ERA. If you have some ideas, let us know. If you like the ERA test as another topic, I could review all the studies to date in one big thing, and we will call it on the ERA. So let us know if you have another idea. By all means, we'll be happy to do that one too. Many thanks to all of you for watching, and we'll see you again soon. Take care, guys. Don't forget to like, comment, and share, and subscribe on our YouTube channel, and go watch that COVID video and the embryo math. Embryo math is probably our best video to date and super important.